Hey everyone, Dr. Shahid here, and in this third and final video on dental trauma, we're going to talk about the biological responses that we can see after a tooth sustains a traumatic injury. And in particular, we'll cover everything you need to know about resorption. When we look at how teeth react to injuries, we've got to talk about two main players, internal and external resorption. Internal resorption happens when the tooth's inner layer, the odontoblastic layer, gets damaged and resorption is initiated by odontoclasts. Think of internal resorption like something eating away at your tooth from the inside. And it could be due to a bunch of reasons like cavities, wear and tear, cracks, getting a knock on the tooth, or even some dental treatments. Basically, it's an angry reaction to bacteria and other nasty stuff seeping from a dead pulp into the tooth's canals. Now, external resorption is a different story. It's when the tooth starts breaking down from the outside. So we get the same damage to the cementoblastic layer as was the case with internal resorption, but this time the damage initiates resorption in the periodontium, and there are a few types to keep an eye on. First, we have inflammatory root resorption. This is when the pulp inside the tooth dies off and bacteria start causing trouble by making their way outside the root to affect the tooth's supporting periodontium. Cervical resorption, on the other hand, is a bit trickier. It happens near the tooth's neck, and it can be kicked off by physical damage, like an injury or some dental procedures, or even chemical stuff, like tooth whitening. Sometimes there's no clear reason why it happens, it just does. We don't have all the answers yet in dentistry, unfortunately. Finally, we have replacement resorption, or otherwise known as ankylosis. Imagine your tooth getting fused to the bone around it after a hard knock. That's what happens here. It's like the tooth and the bone decide to become one. Okay, now, how can we tell whether a tooth is experiencing internal or external resorption? Well, we can look at radiographs. Looking at x-rays to spot internal and external resorption is kind of like being a detective. For internal resorption, it's all about the inside of the tooth. The x-ray shows a spot that doesn't move when the angle changes. The edges are sharp and clear, forming almost an oval shape. It kind of looks like the root canal walls are puffing out, and it's usually in a symmetrical way and evenly dense. Now, the big giveaway is that the normal canal or chamber just disappears in this area. Imagine the pulp chamber or canal just expanding out of nowhere. That's what internal resorption looks like. Now, switching gears to external resorption, specifically inflammatory root resorption or cervical resorption, things get a bit wild. On the x-ray, this resorption moves when the angle changes, and the margins are a mess. They're poorly defined and irregular, kind of like a moth-eaten look. Furthermore, it's usually not symmetrical and the canal shape stays the same. It's not affected. For replacement resorption, though, it's different. The area looks denser, more solid than the surrounding bits, and you'll notice the space around the tooth root just vanishing, followed by bone creeping in to replace it. Which kind of makes sense because that's what literally ankylosis is. The PDL space becomes bone. Okay, radiographs aside, there are also some clinical features that can guide us in determining what is going on with these resorption patterns. Again, starting with internal resorption, the tooth's pulp usually shows a positive response to vitality tests. And this makes sense because for internal resorption to be active, at least part of the pulp needs to be vital. Now, the key to stopping this process is prompt endodontic therapy, and it's usually pretty effective. On the other hand, external resorption, things vary depending on the type. Starting with inflammatory root resorption, the pulp typically has a negative response, indicating that it's non-vital, which again makes sense. For replacement root resorption, this doesn't really hinge on pulp vitality, and cervical root resorption often shows a normal pulp response. So treatment-wise, inflammatory root resorption calls for non-surgical endodontic treatment. For replacement root resorption, root canal therapy isn't very helpful, and unfortunately, there aren't any go-to techniques or medications that reliably work. Cervical root resorption, on the other hand, generally needs surgical intervention to remove the granulation tissue, followed by a restorative repair. Okay, now that we've covered internal and external resorption, let's look at two other biological responses to trauma that can happen. The first is a condition that we actually talked about earlier in our endodontic video series, and it's calcific metamorphosis, aka canal obliteration. Calcific metamorphosis is pretty common after a tooth gets luxated. Actually, it happens in about 27% of these cases. And if you thought that percentage was high, wait. Calcific metamorphosis is an even likelier outcome in younger teeth that aren't fully developed yet, like those with open apices, or after really bad injuries like tooth intrusions, or if the crown of a tooth gets a serious hit. Essentially, the shock and the damage caused to the pulp causes it to calcify, which changes the whole inside structure of the tooth. Now let's talk about the second condition, and I saved the best for last because the next biological response to trauma is actually the most obvious and most common result of damage or injury to the pulp. It's pulp necrosis itself. Now, how often this happens really depends on the type of injury the tooth had. Let's break it down. If a tooth just gets a slight concussion, there's a 2% chance that it'll lead to pulp necrosis. But with subluxation, the risk goes up to 6%. And for the more intense stuff like extrusions, the chance shoots up to 65%. Lateral luxations to 80%, and for intrusion, it's way up there at 96%. And you guys should be familiar with these percentages because we did go over them previously. Plus, the stage of the tooth's growth matters too. Teeth that are still growing have about a 17% chance of pulp necrosis, while fully grown teeth have a higher risk, around 68%. Knowing these numbers, guys, is super important for us so we can figure out the best way to treat a tooth after it's been damaged. Alright guys, before we reinforce everything we just learned with a practice problem, I wanted to give you guys a table that would better differentiate two of the subtypes of external root resorption that we discussed: inflammatory root resorption and replacement root resorption, because I know they can be quite confusing. So I'd suggest pausing the video and quickly reviewing the summary table, making sure all the points make sense to you. Alright, with that said, it's question time. Each of the following regarding external root resorption is true except one, which is the exception. Alright guys, pause the video if you need. And the answer is D. The margins are sharp, smooth, and well defined. Remember guys, for external root resorption, the margins are irregular and poorly defined. It's characterized by a moth-eaten appearance. It's actually internal root resorption that has sharp, smooth, and well-defined margins. Important to know. Alright guys, that's it for this video. Thanks for watching. See you next time.